So good afternoon. Today I'd like to guide you through 3 lamellar macular hole cases. We all know it's a non-penetrating macular hole, and based on OCT criteria, non-penetrating macular defects are classified in pseudoholes, ERM4 and lamellar macular holes. In contrast to the first 2 ones, the lamellar holes show a tissue loss. We have an irregularity of the foveal contour, undermined edges, the so-called LHAP, and at the end, photoreceptor layer defects. The lamellar hole associated proliferation, as you can see here, they look dark in the juxtafoveal region, amorphic structure in histology, in contrast to the elastic epiretin membranes. Nowadays we call it an epiretin proliferation because we also see them in other entities. It's a sign of chronicity. Unfortunately, usually we don't have these typical cases. We have a fluent transition to mixed entities, as you can see here, and this makes the decision concerning the treatment even more difficult. So now that we know what a lamellar hole looks like, can we really manage? I'll start with this patient. It's an 80-year-old lady, visual acuity 20/40, a little bit of metamorphopsia. Not a question to the panel. Heinrich, what would you do in this case? Peel or wait?
Yeah, I would wait ask what the fellow eye is like, and I would wait. Only if the patient basically twists my arm, I would think about surgery. Yeah.
And the other eye is good. Any other comments? Would someone of you do surgery right away?
I will do it a little bit different because this patient has a lamellar hole epiretinal proliferation that talks about chronicity and also ellipsoid zone alteration, ELM probably 2, and a low visual acuity. From my perspective, 0.5 is not very good. So I will propose surgery in this patient. And as I learned from you, using platelet-rich plasma in these patients is a very useful tool.
Okay. So the patient is very happy, doesn't complain about metamorphopsia. Would you go for surgery, Lars?
No, I wouldn't. The patient let decide.
Okay. So let's go to the next case. We waited in this case because it's always a discussion with the patient. If the patient has no complaints, I think it's still best to wait. 64-year-old patient, visual acuity 160, he has metamorphopsia. Would you wait to appeal?
Oh, but this patient, does he realize his metamorphopsia?
Yeah, 2+.
Yeah, okay. So I mean, if you look at the membrane, we are vitreoretinal surgeons, I would probably go ahead and...
Is there anybody in the panel who would not do surgery in this case?
No, I'd have a low threshold for doing the surgery if the patient is troubled. Yeah.
Okay, so just to make sure why the decisions were correct, we did surgery, visual acuity increased, and the patient has no more metamorphopsia. So if we look at the biomarkers, the most important biomarker is the evidence of tractive epiretinal membranes. You can see the natural history of patients having epiretinal membranes. We see a decrease over time. Lamellar holes stay stable for a very long time, up to years. But this changes if they have additional epiretinal membrane. They combined, like we can see here, lamellar hole and epiretinal membrane, they get worse over time as well. So in these cases, I recommend to do surgery. If we change it and perform peeling, then you see that those patients who have epiretinal membranes, they improve. However, lamellar holes, in days before we had the thrombocytes, by the way, didn't get really better. But patients having tractive membranes, in addition to lamellar holes, they get better. I'm getting to the last patient for this afternoon, last lamellar hole patient, 70-year-old, visual acuity 20/30, no metamorphopsia. Who is, now he is, Arndt.
Does he complain of bad vision?
Not really.
I would wait and see because the fovea doesn't look too bad, although there are some outer retinal layer changes.
Roxanne, I show you another scan. Same patient, another scan. Would anybody of you not wait in this case?
I think if a patient is not particularly troubled, then you're not going to lose by waiting. And I would like to see some evidence of progression or a bothered patient before I expose them to any risk. So I would wait.
this is what we did. And mother, you are a little bit more, I wanted to say aggressive, sorry. More keen to surgery, which I usually am always.
No, I will not operate on this eye.
So even
Because
Martha
visual
wouldn't do
acuity
surgery.
is
Sorry,
not,
didn't find the right English.
Visual acuity
Yeah.
is not so bad,
Okay,
and
this-
patient didn't complain.
So this is what we did.
Yeah.
No surgery. We waited. 8 months later, patients came back with a macular hole. So, did any of you recognize anything which would have given us the idea that this might occur?
Can we go back?
Now we have to peel it, obviously. We don't have to discuss this right away. So, was it a wrong decision to wait?
Well, did you, when exactly did the patient come back? Did you, I mean, once you decide not to perform the surgery, you should actually decide to see him every once in a while? Or did you?
Now, meanwhile, if I would decide not to do it, I would see the patient very soon.
Yeah.
Anyway, we went into the literature, and you know that those patients who have macular holes which derive from lamellar holes, they have a relatively poor surgical outcome compared to adiabatic full-thickness macular hole. And since 2000 and I think 2020, we actually should know that there are biomarkers that foreshadow the progression from lamellar holes to full-thickness lamellar holes. It's Jackson and colleagues who found in 50% of the patients hyperreflective stress lines. As you can see here, and if we go back to our patient, there also was a stress line. So we might have seen this, and I don't know whether I would do surgery right now. We have tools, we have the opportunity to use autologous platelets, which definitely can fix such situations as well. Anyway, I think it was a good case for me to learn. I have to thank Julia and Klaas for preparing this case together with me, and I wish you a nice retina.
Thanks, Siggy. Lars Olaf, your case is next. Lars Olaf has a case for